Good morning. Thanks everybody for coming. So this is the session where we talk about babies with hydrocephalus. So this is sort of kind of like your first visit to the neurosurgeon, and what's the problem, what's going on, what's going to happen now, what's in the future. And so how many people here have a child under a year of age who's been diagnosed and just started treatment? No? Under 5? Okay. So most of you could probably give this talk then, because I thought this was about babies. But hopefully we'll, and stop me anytime and ask questions. Oh, I'm one of the pediatric neurosurgeons in Salt Lake, and I run the Hydrocephalus Clinical Research Network, so it's a collaborative group of hospitals and surgeons that are doing research. Not like the stuff you heard this morning in the lab. We do research based on patient care. So we try and learn something from children, and I'm going to talk about it, give an update on it tomorrow morning. But most of my time is spent treating children with different neurosurgical conditions, but big part of it's hydrocephalus. So maybe before I start, are there major things that people wanted to learn this morning? Anybody got burning questions they wanted, and I will try and cover it, or we can come back to it if in question sessions later. Yeah. Okay, I'll talk a little bit about that. What causes shunt malfunction? Yeah, we're going to get to that, I hope. Yeah.
Signs of shunt malfunction?
Yeah, we're going to do that. Okay. Anybody else have? Okay. Yes?
Determining shunt malfunction if you have split ventricles.
Nobody has that answer. We'll try. We'll try.
Okay, we can keep that one.
Okay. Yeah. Yes?
I'm just more curious about as my son's 2, and so as they kind of, when their head kind of stabilizes from a growth standpoint,
Yeah.
if there's concerns from the catheter growing outside of the ventricle, as
Okay.
opposed to like the tubing size can't be changed.
Right. Okay. Yeah, actually, it's very rare. You'd think it would be common, but yeah, I'll try and get to that. Okay. All right. Well, as I say, when I'm going, stop me anytime. So I was going to try and talk about, first of all, who needs treatment, and it sounds like everybody in the room has a child who's had treatment, but I'll just tell you how I think about it. What are the treatment options? Does everybody's child have a shunt, or has anybody in here has their child has had a third ventriculostomy? No, everybody has a shunt. Is that right? Okay. And sort of what happens once you have your first treatment, and what does the future look like? What are the things you need to watch out for? So the first thing, and I think probably better than these statistics, is being at this conference, you realize you're not alone. This is a terribly common problem. So it accounts for, and this is if for under 18 in the country, almost 40,000 hospital admissions a year, and $2 billion in healthcare spending. Actually, that's just charges, and 400,000 hospital days. And you've seen all the people at the conference. So this is something that's common. You're not alone. There's lots of resources, especially the Hydrocephalus Association, to help you get through this. So why does it occur? There's a lot of reasons why hydrocephalus occurs, and that's one of the reasons why it's tough to study, because it's the end result of a bunch of different things. So you can get it from a brain malformation. You can actually get it from a spinal malformation. You can get it from bleeding in the brain. You can get it from infection in the brain. You can get it from brain tumors. You can get it from car accidents. So when you go to study it, those different causes affect sometimes it affects the way you treat it. It affects the way the shunts work and how long they work. So it's not like studying type 1 diabetes where everybody has a very specific thing. It's quite a mixture of different causes. So that presents some challenges. So you probably all started off with something like this. So whenever you go to the pediatrician, they get their height and weight and their head size measured on a regular basis. And this is incredibly useful. This is what starts the whole process. And the baby's bones are all separate, and so when anything builds up in the head, the head just enlarges. And usually, babies don't get too sick in the beginning, and because they can make their head bigger. Eventually, they get into symptoms, but this is the first clue, and this is really important. It's really important because when you look at an image of the brain with big ventricles, it can be because the fluid's building up, or it can be because the brain is shrinking. And there are some terrible diseases that actually make the brain smaller, and the space just gets filled up with fluid. So if your brain's getting smaller and the space is getting filled up with fluid, the head doesn't grow. So that's how you tell, is just by measuring the head. So it's a really simple thing to do. So sometimes it's really obvious. The head is just growing away from the curves, and it's supposed to grow. It should grow parallel to those lines. But if it's growing right away from the curves like that or like this, then clearly there's something going on. And hydrocephalus is one of the most common things, but this could be from anything. It could be from a brain tumor growing. It could be from some kind of a cyst that's growing. It could be from, well, it usually wouldn't be from an infection because that happens so quickly, but the point is any extra stuff in the head will do this. But this is the first clue. So then it's different in babies and older children, as I'm sure you've experienced. So babies usually get irritable and throw up, which they do every day, and they do for any reason at all, pretty much, right? So that doesn't help by itself. So then we look at the soft spot, and it's pretty, if the baby's happy and their head is elevated, then the soft spot should be level with the bone or below. And so that's what we look at. Is it level with the bone, below the bone, or is it bulging above the bone? Now, it's normal for it to bulge when they're laying down. It always bulges when they're crying. It bulges when they're filling their diaper. But if they're upright and they're calm, then it should be soft and level with the bone or below. And then we look at the sutures. So those are the spaces between the bones. And as the head grows, those move apart, and so you can feel a gap. And then sometimes you get into sun setting. Did anybody's baby do that? Yeah, so your eyes are down. You can see the white part of the eyes at the top, and they actually can't look up. That's getting to be a little bit more severe problem. And then some children actually have breathing spells where they stop breathing briefly. So it's different in older children if it shows up in older children. And these are the things that show up that tell you about shunt blockage as well. So they're the same things that occurred before. So in older children, now they can sometimes tell you they have headache. They're not just upset. They can tell you why. You lose the soft spot and you lose the sutures because the bones close, usually in the first couple of years. They can still get the sun setting where their eyes are down and they can't lift them up. They can still get apnea. But the other really important thing is they lose milestones. So instead of learning new things at the different stages, they stop doing that or they actually go backwards. But by far, in older children, the most common thing is just headache. And if it goes on for a long time, they can get these other things, and they can actually have visual problems. But it's different. And again, those things are the way they show up. Those are also the things that indicate that the shunt's not working. So the biggest decision by far in your whole life, if you have children or family members with hydrocephalus, is does it need treatment? So to a certain extent, ventricles are like feet and noses. Some people have bigger ones than others. And the question is, does it matter? And this is the hardest thing we do, I think, in pediatric neurosurgery. When you see somebody who has ventricles like the one on the left, does that mean they automatically need treatment? Or they're a little bit bigger on the one on the right, does that mean they need treatment? And because if you put a shunt in, it's really hard to get rid of it later. And if you if you took a normal baby, you'd never do this, but if you took a normal baby and put a shunt in, they would become dependent on it because the fluid goes down the shunt. The fluid doesn't follow the normal pathways in the brain. So, in any part of your body, if it's supposed to have flow through it and it doesn't, then it sort of scars down and shuts down. So you can, if somebody doesn't need a shunt and you put one in, you can end up making them dependent on the shunt. So it's a huge decision. There's this big dividing point here of, do you treat it? Or do you go through life with bigger than average ventricles, and how big is too big? And this is where I wish we had a better answer. We don't have a good answer. We really don't know, are you better to have a shunt? It'll make your ventricles small very reliably, and it'll make the brain tissue much thicker. So on a scan, you look like the head's full of brain tissue. Is that better, along with the thing that occasional shunt revision, the risk of a shunt infection, and having repeated surgery? Is that better, or are you better to not have surgery repeatedly over the years, but have bigger ventricles and thinner brain? And what you need to know is who's going to have the best brain function when they're 20. And those things aren't known very well. We're trying, but there's a big gray zone in the middle. And that's the most frustrating thing for me. And that comes into the discussion. We're talking about third ventriculostomy, and nobody's had one of those, it doesn't sound like in the room, but where you make a hole in the third ventricle and let the fluid out that way without a shunt. Those children, their ventricles stay bigger. So is that the best thing for their 10, 20, 30-year future? So this is a huge decision. Do you treat or not? For me, I think it's pretty reasonable to say something has to be getting worse. So within reason. So I think even if I see somebody for the first time with a pretty big head and pretty big ventricles, it's really rare for me to treat them right away. We usually watch for a little bit because big stable ventricles are probably okay. But if they start to get worse, their head size progresses, the ventricles start to progress, or they show those other things where they're regressing instead of learning new things, then clearly you need treatment. But there are exceptions, but it's pretty rare for me to make that decision the first time we meet, and because you're making a lifetime commitment, for one of these treatments. So there's a couple of causes of hydrocephalus that deserve some special comments. So one is spina bifida, and those children, I don't know if anybody in the room has a child with spina bifida, but they get surgery. When they're born, the back is open. You can see the spinal cord, and you do surgery to close it. And so they might not get a big head. They might just leak fluid through the back. So that's a little bit different. They might go home without a shunt and then find that there's spinal fluid leaking out, which basically looks like tap water. And if that happens, then they probably need treatment. The other thing that those children can do is sort of get hydrocephalus in the spinal cord. And so that's what this is. Instead of building it up in the head, you can see this is right here, this is fluid built up in the spinal cord. And kind of like the ventricles, if we see that, you don't automatically treat it right away. But if they didn't have it and then they develop it, or if they have a little bit of it and it gets worse, then you're probably going to end up treating the hydrocephalus. Yeah?
Our daughter has a series of spinal cord, there's shunt.
Yeah.
Very cool, that's something.
The shunt, to put the shunt in the spinal cord, yeah. Yeah, no, sometimes you end up doing that. I think most of the time, if they don't have a shunt in their head, you treat that first. But that sometimes you still have the thing continuing to enlarge. Yeah, and that's a... Sorry?
Yes,
4 in her spinal cord. Wow. Yeah. Yeah, it can be a tough problem. But yeah. But usually you start off at the top and treat the shunt first. Yeah. Oh, sorry.
If you have a shunt already and your neurosurgeon starts to see fluid in the spine, is that a symptom of a malfunction of your shunt then?
Could be. So it could be a few things. It could be that the shunt's not working. It can be caused by this right here. So children with spina bifida have what's called a Chiari and malformation, which means that some of the tissue of the cerebellum is kind of hanging down into the spinal cord area, and that can cause a syrinx. There's another problem that they get called tethering, where the spinal cord is stuck down. That can cause a syrinx. And so the simplest thing, probably the least risk operation, if they have a shunt and they develop a syrinx, is to revise the shunt first and make sure that's working before you start doing another operation here, another operation down in the back. That's a generalization, but pretty good rule of thumb. Yeah. And this is the other one. So spina bifida children who have big ventricles, and they start to get symptoms from their Chiari. So the symptoms from the Chiari are pressure down at the bottom of the brainstem here, sort of the top of the spinal cord. So the nerves there go to swallowing, and they go to the airway. So children who develop stridor, or sort of noisy breathing, they develop swallowing problems that they didn't have before. And they hadn't had a shunt. Then you don't start by treating down in that area, you start by treating the hydrocephalus. Okay? So just a couple of exceptions to the general rule, but for me, again, something has to be progressive over time. The other category, excuse me, the other category that's a little special is the, sorry, the premature baby with bleeding. Talking about trouble swallowing. Thanks. This is thank you. The premature baby that has bleeding in the brain. How many people are in that situation? It's a fairly common one. So this is an ultrasound, and it just shows. This is the way it's oriented is if you're looking straight at the child, and these are the ventricles, the black, and this is blood in the ventricles, there and there. And so it plugs up the drainage, and the fluid builds up. That's a group that can't be treated right away. They're too small to have a shunt. Sorry, I'm going backwards here. They're too small to have a shunt. The infection rate's too high. I mean, how big was your child? Your son? Yeah, what did he weigh? 5'11". So he's small, but not as small as some of them. I mean, some of them are, yeah, right. So some of these children are really, really tiny. So they're too fragile to do a big shunt operation. Yeah.
Oh, I was just gonna say mine was 1 pound. So
Yeah. Yeah, that's right. So you got a baby like this, and you can't go and put a shunt in. So they end up get treating with some kind of temporizing measure to just let them get bigger, but you have to manage the fluid until they're bigger. And this is one of a couple of the common ways of doing it. You put in a little tiny reservoir, so it's a tube that goes in the ventricle, and there's just a little plastic bubble sitting under the skin, and the intensive care docs can take fluid off of that whenever they need to. But in our research group, we've done a lot of studies on that, and there's a lot of variation in how doctors decide to do this and when to do it. And so we've gone to a pretty standard way of doing it. They have to have enlarged ventricles. They have to be under 1,500 grams, which is pretty small. And then we have to have 2 out of 3 things. They have to have spells where their heart slows down. They have to have their sutures split open, and they have to have the bulging, the soft spot bulging. And so if they have big ventricles and 2 of those 3 things, that's how we make the decision to treat in that specific group of children. And so we've now standardized that across our group of hospitals that are working together to try and do things consistently. So again, that's the biggest decision is, do you need treatment at all? Because you go down a completely different pathway, and but everybody in the room has already gone down that pathway. So let's talk a little bit about how you treat it. There's no pill, unfortunately. Some of those things we heard this morning are exciting, but right now and for the foreseeable future, there isn't a pill that will, reduce the production of spinal fluid or stop it. And so we're talking about some kind of surgical treatment, and shunt or third ventriculostomy. And I think I heard at the very beginning, nobody had a third ventriculostomy in the room, right? Oh, Susan, okay, phew, okay. Did you? Okay. So, so you'll be familiar with a shunt, the tip sitting in the ventricle, some kind of a valve somewhere along the system, and the tube running down to the abdomen. This is a close-up view of a third ventriculostomy. So for those of you who haven't had it, the floor of the third ventricle right there is really thin. You can see through it if you look inside. And so what this does is you go in with a scope, I think I have some more pictures of it later, and make a hole in the bottom of the third ventricle so the fluid can get out that way. So here's one that's had the hole made, and now the fluid can get from the ventricles to the outside of the brain. Instead of taking the fluid with a shunt to the abdomen, you get it out through this hole in the floor. So we'll come back to that. So shunt surgery, there's a few decisions that we have to make, and there's a session later today, I think it is, by the shunt companies on the different equipment that they produce, and so that might be something of interest. I think that's just after lunch. But the first decision we have to make is what valve to use. And these valves, the original design of valves was that they would just open and close based on pressure. So if pressure builds up, it opens and it drains for a while, and then it shuts until the pressure builds up again, and then it opens again. And it's a pretty simple thing. They've now designed adjustable valves, and some of you might have an adjustable valve, or your child might have an adjustable valve. And basically, they can adjust the pressure at which it opens. So you have to get more pressure or less pressure to open it. And then there's all kinds of other designs of shunts that have come along that these guys will talk about this afternoon that adjust the flow rate in different ways. The thing to remember if your child has an adjustable shunt is most of them, and this is getting better, but most of them are still adjusted by a magnet. So these are a couple of examples, but this is one where you place this thing over the shunt just in the clinic room, and then you can adjust the setting here on the box, and it'll turn the setting on the valve. This is another way of doing it, but these are all based on magnets. So magnets can change the setting of your child's shunt. There's been a bunch of studies on how much of a magnetic field is there from a hairdryer, how much magnetic field is there from different sort of everyday use things, and most of those things have no impact on a shunt. It has to be a pretty strong magnet. But when they have an MRI, it can change the shunt for sure. And at our place, and I'm sure it's the same at yours, after an MRI, you have to go to the clinic and get your valve setting checked and make sure it hasn't changed. And the companies will probably talk about this afternoon, but they're working on valves that don't change with exposure to MRI. But it's something that you need to keep in mind. Yes?
If this question takes us somewhere else, that's fine. I can ask it later, but I'm curious about the decision that goes into, for you, what if you use a programmable or not. Our neurosurgeon pretty much never does. On very, very, very rare occasion. And so we didn't even know that there were such things as programmable until we went to our first conference. So I'm just curious about the, I don't know if you can only speak for you or in general, what goes into the decision on if a young child, what kind of shot they get.
So we did a few studies on that, and so I don't use them at all. But some people, quite a few people do. So our clinical trials showed no difference whether you use an adjustable valve or a non-adjustable valve, and that's why I don't use them. The limitation of those studies is they were done in babies, And probably these have more of an advantage in older children. And they clearly seem to have an advantage in adults with normal pressure hydrocephalus, because you can start with the setting quite high so that it doesn't drain too much, and then gradually bring it down. And so that's the whole rationale behind these. Babies aren't upright very much, so they don't overdrain nearly as much as an older person who's up and around. So I don't, and the adjustability is just another thing to go wrong, right? And then I think that you can mistakenly ignore a shunt malfunction by just fiddling with the valve for a long time. So they're amazing technology. They really are, and maybe we just don't know how to use them yet. But I like things to be simple and things that I can understand, and so I haven't used them much, except in very weird circumstances where, I've had a couple of children that had the brain collapsed a little bit, but not badly, and we were able to use an adjustable valve, turn it up, and have the brain sort of go back into a normal position. But I'm talking 1 or 2 in the last 25 years. So, so there's nothing wrong with them. I'm not convinced in the baby that they help, but if you have one, just don't forget about the magnet issue and the MRI issue, and I'm sure your surgeons would make sure you're on board with that. The other thing to know with these, and we got this out of one of our studies when we studied it, is when children come in with headache and they have an adjustable valve, if you change the setting, you know quickly, like in a day or two, if it's going to help. I think that 2/3, and this was a study of a few hundred children with an adjustable valve, 2/3 of them got better by adjusting the valve, but of the ones that got better, 90% of them got better in the first day or two. So, and this is really, you should be aware of this. So if you go in and you get your valve adjusted and a week later you're no better and you come back and somebody says, well, let's adjust it again, you say, are you sure it's really working? And so you should know it, but we always tell our residents this, because they're running around, they're really busy, and somebody comes to emergency and they have an adjustable valve and they say, oh, this is easy, I can just adjust the valve and see if it works. Then you go away and you come back 2 weeks later and you come in and you see another resident and he said, oh yeah, this is easy, I can just adjust the valve and see if it works. And I've had that happen. I've had children who aren't really sick, but they're symptomatic, and it goes on and on and on. And the shunt wasn't working and they needed a revision. So it may be a useful thing, but the point is that if just adjusting the valve is going to work, it doesn't take long to figure it out. So there'll be a lot more on valves this afternoon, and the companies will be there. They're going to actually do the presenting, and I think that's great, because it's like you're getting to talk to the guy that designed your car. You don't get to do that very often, so you can give him some feedback. The other decision that we have to make is the antibiotic impregnated shunts, and yes, they do help decrease infection. There's other things you can do and decrease the infection about the same amount without the antibiotic shunt. So it's kind of you want your surgeons to be doing something about infection. And we've done a bunch of studies, I think I'll mention these tomorrow as well, that if you have a standard protocol, if you do it the same way every time, if you wash your hands the same way and do all the prep the same way, because this is something we do over and over and over, just decreasing the variation in practice and doing it again and again reduces infection. But the catheters are a part of that. Okay, so maybe why don't I stop and take shunt questions, if there's any others. Yeah.
You mentioned you don't use programmable shunts very often.
Right.
What do you do in the instant that the patient would need a change in flow, pace or speed?
What would it do, sir?
How do you adjust it at the...
You can't.
Okay. So what happens if it's too fast or too slow?
I just haven't seen that. So I don't think I have the data on a slide, but we looked at that. And if you use an adjustable valve or a non-adjustable valve, the number that are still working at a year is identical. And there's another study that we didn't do. It was done in children and adults, and the same thing. And it was done for first-time shunts, and it was done for revisions. That the survival curve of the shunt, in other words, the number that are still working over time, was identical. So, as I said, I think it's just another thing to go wrong. There's nothing wrong with using them. We just don't have the data that says adjusting them makes a difference. But this is a very individual condition, and as I said at the beginning, there's so many different causes of hydrocephalus. I don't think we understand it all perfectly well. So there may be situations where it's very helpful. But to say we have the data that everybody should be using them, we don't. Yeah.
So our son's overdrinking, he's having symptoms. He has a fixed valve. In that kind of situation, like, what would you do for a child like Leo's having overdrainage issues?
Well, I guess the first question is it overdrainage? And it can be hard to know. And so if it's, and children with shunts get all the other things that other children get. So they can get headaches for other reasons. And so you have to make sure. Usually we get a neurologist involved to look at all those kind of things. And they often treat them with migraine medicine. And that can help a lot. They also, we also have children who spend 20 minutes at lunch, if they're at school, laying flat. And that helps them to get through the day without symptoms. If they've done all those things and it's still a real problem, they're missing school and everything, then sometimes we'll measure the pressure. And so that means putting a pressure monitor in and saying, is this really low pressure? Because once you start chasing low pressure, it's not a minor thing. And if it is, then we'd probably change to a slower draining shunt. Yeah. I mean, they'll explain that this afternoon. A lot of the shunts have that incorporated now. Yeah. So when I say I don't use an adjustable valve, there's still valves that, I was almost going to say sort of self-adjust. As the flow rate increases, the resistance increases, so that you don't have to do something externally to adjust them, but they respond to changes in flow rate. The technology is amazing now, it really is. But
so you would still advocate for a fixed valve with anti-siphon as opposed to doing adjustment?
in general, yeah, but each circumstance might be a little bit different, but yeah. I'd probably use an Orbis Sigma valve, which is the slowest valve that's made.
What about the anti-siphons that are connected to the tubing versus part of the valve?
Yeah, I've never used those. I don't know much about them, but I think that those were used for years before we had the anti-siphon stuff in the valve. So it'd probably work fine. I would bet, yeah. Yeah.
So are you saying that malfunctions happen regardless of what it is? It has nothing to do with the actual valve? It doesn't matter if it's programmable or not?
Yeah, malfunctions, yeah. Right, so the data that we have says that the malfunction rate's about the same, whether they're programmable or not, by a year. Yeah, the exact same number have had to have another operation.
What is the data usually about average, or how long?
For shunt failure, it's about 60% of shunts are still working fine by the end of a year, about 50% by 2 years, and about 40% by 5 years. So.
Check something that would make it, like our daughter went through 2 already this year, since we got back from Minnesota. She went through 1 the year before and 4 the year before that. Wasted me on a brush.
Yeah. No, what I just quoted is just averages, and there's tremendous variation. And we always tell families that up front. We have children who, it's 10, 15 years before they have any shunt problem, and we have some children who have 10 operations in the first year. And there's some things we know that influence that. The two things that really influence it are age. So the younger you start, the more trouble you can have, and the cause of hydrocephalus. So the premature situation is a tough one because they get the bleeding in the brain causes inflammation, which causes scar. So you can get little compartments sort of walled off, and so you end up having to try and communicate them, or sometimes you have more than one shunt. That was really exciting this morning. They were talking about that Decrin that decreases inflammation, but those things are quite a ways off. And yeah.
Sarah brought up the point about the over drainage, and how do you know? I mean, I don't even know. I hear that term used all the time. I'm over draining or I'm under draining, and I have absolutely no idea what that means.
That means you don't have it.
How you would know that?
Okay, that means you don't have it. That's good. But it shows up like obstruction. Actually, I'll show you that.
It would be that my child would be symptomatic as though the shunt were malfunctioning?
Yeah.
Okay.
You
Yeah.
see, like as kids go longer with the same shunt, so say you have a kid that's 10, 12, 15, get their original shunt, and then the shunt malfunctions. Is it more difficult to get the shunt correct again after being so in-house of a specific type of shunt now that grown?
In general, no, but I think the rule is use the same one. So whenever we're fixing a shunt, I always put back, if somebody's had a shunt that's worked for 10 years, use the same one. And actually the valve usually isn't the problem. So leave it alone. We don't change the whole shunt, we just change the part that's not working. So you do get into those situations where the valve isn't no longer available, or we have this bright idea to try a new valve or something, and you get into problems. But if you go back to the one that's worked is the best thing.
Because they've grown so much, that's usually not a problem. Like you just hear some horror stories where it's like they had this shunt, now it's failed. They're a different person, obviously, so it's hard for the doctor to
get it right again.
Yeah. And it's a nightmare.
Yeah, we do run into those. We don't understand them very well. You do everything the same, but yeah. So is it from growth? I don't know. I think it's probably by that time they have small ventricles, and it's more difficult to sometimes to get the shunt in the right place and keep it working, I guess. I don't know. Yeah.
Does it matter where you place the shunts? Like when you insert it on the left side, the right side, the front, or the back? Like, and what goes into the decision for a doctor when choosing that?
So right and left doesn't matter. Assuming that everything communicates, which it usually does in the beginning. Front and back's an interesting thing. So if you look around the country, there's people that do both. So if you come in from, well, there's on that picture, this is obviously coming in the front. You can also come in from behind, and then the catheter runs like that. So the tip ends up at the front usually, but you enter from behind. So there's we've got some data from our network that says that the front might last longer, but there's also a randomized trial from 20 years ago that says the back lasts longer. So actually we're in the middle of a study doing that. It's going to take a few more years, but when children come into one of the hospitals in our research network, they get asked if they'd be willing to be in the study, and then we flip a coin, put it in the front or the back, and we'll, yeah.
Depending on if the child becomes part of the study or not. And if they're not part of the study, where do you generally?
I know, that's what families ask. I don't know what to say, because I started my career putting them all in the back, and then I moved to a center where they always put them in the front, so I did it the same just because we treat each other's patients so much. I suspect it doesn't matter. Yeah. Yep.
Can you grow out of the need for
It's extremely rare. So in general, children with spina bifida, the answer is no. Children with premature with intraventricular hemorrhage. I think I have 2 children in the last 25 years where they come in for some reason, they get a chest x-ray and you say, oh, the shunt's broken. And they're fine. So they send them to see us and you look at the eyes and make sure they don't have pressure. And they seem to be fine. And so you wait a couple months and you do another scan and they're still fine. And then you wait 6 months and you do another scan, they're still fine. And you really worry about them and check them really closely. And 99.9% of the time you end up putting the shunt back. But as I say, I think I've got 2 in the last 25 years. So I think it's false hope to tell families up front that someday you'll get rid of this. I don't. I just tell them up front, this is a lifetime commitment. Yeah.
What about with choroid plexus papillomas that were removed? Do you see that the children, because you removed the tumors, so down the line, do you see them outgrowing, not needing the shunt anymore?
Well, not all of them need a shunt in the first place. So for those of you who don't know, this is a tumor that makes CSF. And so if you remove the tumor, not all of them need a shunt. If they need a shunt, then it's probably because the pathways for the spinal fluid have scarred down. So the surgery, you get some bleeding, and then you get inflammation and scar. So no, I don't think that's any different than any other tumor. But they don't all need it up front. Yes?
So my son, they tried the ETV and it didn't work, so they went ahead and put the shunt in. Is that common?
Yeah. Yes. So well, actually, I think I got a couple more pictures of that. So the ETV, yeah, the ETV can fail just like a shunt can fail. And the overall failure is about the same. You take a little bit more risk up front with an ETV because they fail more commonly in the beginning. If you have an ETV and you get beyond a year or 2, then they fail less than a shunt. But
so his did it right through surgery. Like as soon as he tried, he called out and said, this isn't working, we're going to go ahead and fix the shunt.
okay. Well, that may be where they looked and they couldn't do it or something like that. Because you're looking, like that picture on the left, you're looking at the floor of the third ventricle. That's where they have to make the hole. On the other side of that membrane is a big artery that brings blood flow to the brain. If you can't see that artery, you don't want to sort of blindly poke, because if you make a hole in that artery, it's a disaster. So yeah, sometimes we'll do that. We'll say, we think we might be able to do this, but if we can't see clearly, we're going to back out and do a shunt.
My other question is, he's had a shunt for almost 7 years now, and he still has very enlarged ventricles. Is that common?
Yeah. Do you know what kind of valve he has?
He has just a regular, non-programmable valve.
Different, yeah.
Yeah.
Still, in the non-programmable ones, there's a bunch of different ones, and some of them intentionally keep the ventricles bigger than others, so it depends on the valve, maybe. Yeah.
Do you find as a child gets older, my understanding is when they're really young, like 2, 3, 4, their brain's really stiffer, and then it softens as we all age. Does that make shunt malfunction symptoms like more tolerable for the body as opposed to like, immediate headache, vomiting?
I don't think so.
Maybe taste like numb.
No.
So if you have a stiffer brain, is that going to be?
Is it kind of protective, you mean?
Forever?
Oh, does your brain stay like that? I don't know. Except for what Pat presented this morning, we don't have any way of measuring the stiffness. But what I can tell you is that from one child to another, the way their blocked shunt shows up can differ from one child to another, but within the same child, it's usually the same.
And that goes from, 2 years old to 25.
Yeah, it does. It can change from when they're a baby to when they're 2 to 5 years old, just because the bones are closing, but then it stays pretty much the same. And that's why we always hammered into the residents to listen to you, because you guys know. You can tell us. We don't have to do anything. You say this is the shunt, and you're usually right. Yep.
With his enlarged ventricles, when he started first grade, he was doing great, and then like October came, and it was just like he forgot how the classroom ran, what he needs to do, his memory and everything was off. So I took him back, they did an MRI, and they just keep saying it's stable. But at what point do you gotta worry that all these regressions are due to
Yeah. That gets back to that thing I was saying at the beginning, is we don't honestly know if you're better to have shunted small ventricles or big ventricles. And if he's getting into regression and that kind of stuff, then I guess there's two options. One is to just revise the shunt and make sure it's working, or the other would be to measure the pressure. You have the eye doctors look in his eyes and look for signs of pressure. Really? Yeah. Yeah.
A question not related to shunts, but can you develop Chiari or any other symptom, hydrocephalus-ish, like water, spinal injury or something from a shunt or anything else?
Can you develop a Chiari from a shunt?
Or just in general, like if you already have a shunt, can you end up getting Chiari later and not be diagnosed with your original diagnosis?
Not likely. No, I mean, if you have untreated hydrocephalus, you can develop a Chiari. But that's not really a Chiari, it's just the fluids push the brain down. A Chiari is something that you're born with usually. So I don't think so, no. Yeah.
Not shunt, but going on to Chiari, how likely is more than one knee compression? We've already had one, and we're looking at the second one, but it seems like most people.
Yeah, it's not very common. You occasionally get into that situation. That the benefit from each, not just Chiari, but any repeat operation, the benefit sort of gets less, but sometimes you end up having to do that. Yeah, not very commonly. Yeah.
So our son's Chiari has improved.
Has what? Improved? Yeah.
Since his hydrocephalus has been treated?
Yeah.
Does it tend to stay that way?
Mm-hmm. If the shunt's working. Let me just, I think I got some stuff about shunt failure in here. So when you do the third ventriculostomy, this is what we're talking about. So normally the fluid is produced into the lateral ventricles, which you can't see because this slice in the brain is right in the middle. It flows down into the third ventricle here, and then it normally flows down there. That's the aqueduct. This is the fourth ventricle, and then the fluid gets out. And so here's a situation where the aqueduct isn't open. So the fluid comes down here, and it can't get through right there. And that's a malformation. That's aqueduct stenosis. It's not from an injury or anything. It was just, it didn't form properly. So the third ventriculostomy creates a hole right here, and you can see the hole, and you can see this, the black stripe. Anything on an MRI, if something's flowing, it's black. And so that's fluid flowing through the third ventriculostomy. So instead of the shunt taking the fluid to the abdomen, this allows the fluid to get out. Now, it only works if there's a blockage like this. Because remember, the fluid has to get out of the brain, and it has to go around the brain, and it gets absorbed into the sinus, this big vein at the top. So you can get hydrocephalus because the problem's up here. The fluid's not getting absorbed. So then it doesn't matter how it gets out of the brain, it's not going to work. If the fluid gets out this way or this way, it doesn't matter if the absorption mechanism at the top isn't working. But if the blockage is along here or somewhere inside the brain, then this just gives the fluid a different way to get out. So that's the whole rationale behind a third ventriculostomy, and it's really only maybe 2 out of 10 children with hydrocephalus where it might work. So you do it by, you put a scope or a camera in like this, and then you're looking down at the third ventricle. So here's the view that you get, and there's this natural opening here into the third ventricle, so the scope actually goes through that hole, and you get down to where you can see the floor and make a hole in it like that. But as I said, these can plug up just the way a shunt can plug up. The thing that's been going on in the last 5 years is doing the third ventriculostomy and coagulating the choroid plexus. So the choroid plexus makes fluid, so the rationale is if you coagulate it, you're not going to make as much fluid. It's an interesting story. It started in Africa. Some of you might have been familiar with it. So Ben Worf's a neurosurgeon in Boston now, but he was practicing in Uganda, and he was there for 6 or 8 years, I think, and he had trouble with access to shunts and also trouble with follow-up of children with shunts. And so this is actually a really old operation, both of these, the third ventriculostomy and coagulating the choroid plexus, and he decided to do them together. And because he didn't have enough shunts, and it seemed to work. So it's a story that's spread from an underdeveloped area of the world to North America, and so now lots of people in North America are doing it. And basically what it's done is it's increased the number of children that can have third ventriculostomy. So we used to say that if you're under 1 for sure, maybe under 2, then it's not going to work. But this has allowed us to try and do it in younger and younger children. But it goes back to the original problem. It leaves the ventricles big. And I can't tell you if that's going to be good, better than small shunted ventricles when it's time to apply for college. So we're doing a bunch of studies on that to try and figure it out in a bit more detail. But this is what I was talking about earlier. So the third ventriculostomy, if it fails, it usually fails early. So this bottom curve here is a third ventriculostomy. So this is how many shunts are still working over time. So you can see that a lot of them fail, and the shunt is doing better. And then when you get out, this study said 2 years, but somewhere you get out there, and then the third ventriculostomies kind of level off, and the shunts keep falling down. And there's different curves for from different data sets, but this is generally, most people find this, that you take more risk in the beginning, and but if your third ventriculostomy lasts a year or 2, then they can fail later, but it's less common. And then the other issue is you got big ventricles with one, and you've got small ventricles with another. Yeah.
So you have, my son had his ETV revised. Any data yet on what the curve changes if you have a revised ETV?
I don't have the data off the top of my head, but I would think he'd probably get back on the curve. Yeah. First of all, it's not always you can open it. So the question is, if your third ventriculostomy blocks, can you reopen it, and do you do just as well as if it never blocked? And you can't always reopen it. Sometimes you go to reopen it and you find that it is open. So if you go in and you find it is open, that means that the blockage probably wasn't the right operation in the first place. Because if it's open, the fluid blockage is downstream somewhere. But if it was working and now you go and reoperate on it and it's closed, sometimes it's hard to reopen because it's closed with scar tissue that can be thick and you can't see where you're going. But if you can reopen it, then I can't quote the data, but I bet you're pretty close to the original curve. Yeah.
Is any research being done in regards to neurocognitive development, which is more beneficent for larger or smaller ventricles?
Yeah.
Long term?
Yeah. So we're doing a bunch of studies. One's on the preemie children with bleeding, and their outcome is a Bailey's development scale. So we're looking at their development at 18 and 36 months, I think. We're just going to hopefully start a trial where children either have a shunt or a third ventriculostomy, and the outcome is going to be, it's a developmental outcome. I can't remember which one it is. Anyways, yeah, but those take years. That's the problem, you know. So you can do a study where you can say who's better off at 24 months. How predictive is that of the 20-year outcome? It probably is somewhat, and that's better than nothing. But it's really hard to do those studies over the year, you know, over decades. Let's see what else we've got here. Oh, so this was a review, and we've talked about a lot of this. You know, so you get treated, so go home. And I always tell families, just go home and enjoy your baby. You don't need to do anything special at home. You don't treat them any differently than any other child. You don't need to position them any certain way most of the time. There's rare exceptions, but just try and carry on with life. But then you need to know what to watch out for. And we've talked about a few of these things, so I'll skip over it if we've already done it. You come for regular follow-up, and some people don't. It's really important because I'm sure that if you've gone to the effort and expense to come to the conference, you probably come to your follow-up visit. But some people don't, and then they end up with these, and the children often don't get symptomatic. Their head's just growing too fast, and so they get big problems later because they've had a prolonged gap in follow-up. And really it's just head size and then some imaging, and people vary a lot on how much imaging you need. This is what we know. We know that the ventricles come down in size somewhat by 3 months after a shunt, and they come further down in size by 12 months. So I always get a scan, usually at both of these time points. But we always want to get a scan around a year after the shunt's been in place. And that's the baseline for future assessment. Because anytime you come in, they're going to do a scan, and they're going to look at your old scan and say, are the ventricles bigger? I think I got a picture of that here in a second. But it looks like the flu. They get irritable, and they throw up, and they get sleepy. And if they have a fever and diarrhea, you can relax. They probably have the flu, and they're going to get the flu someday. But if they don't, then you got to come in and get evaluated, and usually ends up with some kind of imaging. And the spina bifida kids are a little bit different because they can leak fluid after they go home. But any shunt kid can leak fluid after they go home through the incisions. That's bad. Don't wait until Monday. Call the neurosurgeon, because the biggest risk for infection is fluid leak. So if they're leaking fluid, you don't want to leave it all weekend and come in on Monday. They're going to get infected, pretty sure. And usually they're leaking fluid because the shunt's not working. If it can go down the shunt, they probably won't leak fluid. So, and spinal fluid looks like tap water. Sometimes, if it's a recent operation, there's a little bit of blood mixed with it, but it doesn't clot like blood. It's runny and watery. And how are we doing for time? Okay. What's that? Are we? Okay, so yeah, there's nothing there terribly useful. Let's just take some more questions. Oh, a couple comments. So if your baby has a fever, and it's soon after the shunt operation, then you should get checked out for an infection. If it's beyond 6 months, it's really rare to get an infection. So it's going to be something else. So because we get asked all the time, every day almost, there's a child in the emergency department who's had a shunt, and they haven't had an operation for 2 years, and they have a fever, and they want us to tap the shunt. I think you're taking more risk by tapping the shunt than you are by looking for all the other causes of childhood fever, because the infections are from surgery, and they're in the first 6 months. And the other thing is, if you're not sure, and we tell the residents this all the time, just wait, just watch. If they have a fever and it goes away the next day, it's not from the shunt. And if they have symptoms of shunt malfunction, they might be the flu. Those will go away. So if it's clearly a malfunction, you fix it. But if you're not sure, you probably have done this, we'll often watch you in hospital for a night or two and see what happens. Time will tell. So this is just to say it's not all doom and gloom. Shunt survival is getting better, and we're still working on it. Sorry, so let me stop again and take other questions. Yeah.
Can you talk about intracranial monitoring? There have been times where my son has had something that could be a symptom of ETV failure, and we've talked about the idea of doing the intracranial monitoring, which just sounds incredibly barbaric to me.
It does. It's not bad. It looks terrible. So there's a few different brands of monitors. The one we use is like a little fiber optic cable. It's a millimeter or two. It's an operation to put it in. So you have to have an anesthetic, and you make a 2 millimeter hole in the skull, and it actually goes into the frontal lobe of the brain. And then there's a screw that screws in. And it sounds barbaric, but they're sound asleep. And because you don't want, it has to be rigidly held in position because you don't want that thing wiggling around in the brain, right? So it looks terrible. They come out of the surgery and they got this thing sticking out like this, and then there's a wire going to a monitor. But they sit up and watch TV and eat breakfast, and you're on a bit of a leash. You can't go very far, but you only have to do it for a night or two. And it's incredibly valuable. It shows you, sometimes you get iffy results and then you know better, but most of the time, a lot of the time, we can say, this is not a pressure problem, your pressure is normal. We should be looking at neurology with migraine medicines or something else. Or sometimes treat depression. Kids get depressed and they get symptomatic from that. Or, yeah, clearly your ventricles haven't changed, which is rare, but you clearly have high pressure and we need to do something about it. Then there's a gray zone. And we don't do it that often, but probably 2 or 3 times a year we'll be in that kind of a situation. So, and then the removal is not another operation. You remove it at the bedside. So it looks terrible, but it provides you a lot of information, and
I think the risks of it don't keep you up at night.
No, the risk is infection and bleeding, and they're probably, I don't know. I think your risk is higher by ignoring it. The risk of bleeding it's literally like a centimeter into the brain. And if we've had a hemorrhage, I didn't even know it. But if you did some scans, you'd probably occasionally see a little bit of blood beside it. But the risk is really low. Yeah. Yes?
I don't know when you said you tap a shunt. Could you explain what that means?
Oh, so you just, so the shunt has a reservoir on it, just like a plastic bubble. And you sterilize the skin and put a needle into it and take some fluid off. And then you can send it to test for infection. Yeah.
Is that painful, or do you not feel it?
It's a needle poke, but often the scar makes the area of the skin right behind the scar numb. So it sort of depends on the angle of the incision because the nerves to the skin come like this and like that. So depending on how the incision's oriented, it might be, that area might already be numb. If not, there's Emla cream, so that's a cream that you can put on that numbs things. Yeah.
Again, about tapping the shunt. You mentioned like the risks of tapping the shunt, because to me it seems like a really great, quick tool to see if it's working. Like before an MRI, before an MRI or more exposure to radiation or whatever. Why is that like one of the first steps?
2 reasons is the infection risk. It's really low, but it's not zero. And then the other reason is it's not very reliable for testing if the shunt works. So because we're often doing this in a situation where the ventricles are really small. And so you don't get a whole ton of fluid pouring out. You might get a drip, and then you're saying, okay, well, is that because the ventricles are really small or because the shunt's partially obstructed? So I haven't found it to help for that, to assess shunt function. I mean, occasionally, if there's lots of fluid and you can easily draw fluid off, it might help. And some people do it a lot in that practice. I just haven't found that the times that I needed that information, it didn't really give it to me. So we only usually do it if we're checking for infection. Yeah.
Can you talk about the difference between having small shunted ventricles versus like split ventricle syndrome?
Well, Yeah, for those of you who haven't heard of this, so slit ventricle syndrome is got this label 20, 30 years ago. So everybody who has a shunt over the years ends up with very small ventricles. And 90% of them are perfectly fine. The children that have what's called slit ventricle syndrome have really small ventricles and a lot of headache. And it's a tough problem because well, first of all, are the headaches related to the shunt is the first question. And that's when we sometimes get into the pressure monitoring situation. And then what do you do about it? Well, one rationale is, well, it'd be nice to make the ventricles bigger. The reason people think that might help is because one of the theories about slit ventricle syndrome is the ventricles are really small and the shunt's in there, and so the ventricle walls kind of collapse on the shunt tubing and block it. So the pressure builds up, they get symptomatic, and when the pressure builds up, the ventricle opens up a little bit and it drains, and then they feel better, and then it collapses down again and it blocks the shunt. And nobody knows if that's real, but that's what we think might happen. So if you believe that theory, the rationale is, well, if you make the ventricles bigger, you won't get into that kind of a situation. So how do you make the ventricles bigger? You use a slower shunt. There was an old operation called subtemporal decompression where you would literally take the bone off and leave it off so the brain could bulge out and make the ventricles bigger. But it's a really tough problem. So the whole idea that that's maybe one advantage of having bigger ventricles, right? So use a slower shunt that doesn't get you in that situation in the first place. That's one thing to think about. The other thing to think about is that really what's going on? Are there things that the neurologists can do to treat the symptoms rather than repeated surgery? And that subtemporal operation, I don't think anybody does anymore. It didn't work very well. But so what was I forgot your question now that I.
Oh, I was just asking, is there a timeline and between, looking at scans?
Oh.
If their ventricles look, normal with the shunt placed, and then is there a chance that they could ever be slit ventricle?
Yeah, so no, but that's the important thing is most people have what you'd call slit ventricles on a scan if they've been shunted for years. But very few of them get symptoms from it. Yeah. Mm-hmm. Yes.
About if there is a need for a revision of the shunt, how do you determine if there's an issue with the valve tubing? How do you decide what
Yeah, it's hard to tell before the surgery unless it's actually broken. You can sometimes see that on an x-ray. So the question is, how do you decide what the problem is when the shunt's blocked? You decide during the surgery. So you open it up and you test and see if there's fluid coming out of the top end. And if there isn't, you change that. And then you hook up the rest of the shunt to a column of fluid and make sure the fluid flows down through it. And you can measure the pressure. And that way you can tell if the bottom end's working. So it's during the surgery so we always tell families that we don't know if we'll have to fix the top end or the bottom end or both. And we have to figure that out during the operation. Okay, getting the time signal. All right, so enjoy the conference. Go to the session with the shunt companies. I'm going to be there, but I'm not going to really say much, but they're going to tell you about some of their different shunt designs, and that might help us understand some of these things too. All right.